Okay. Now, cranial nerve number 3, right? Now, first, let's talk about generally what is cranial nerve number 3. That's an oculomotorious nerve, right? So it's a motor nerve that innervates all the eye muscles around the muscles, except 2 muscles, right? Now, usually what we see, SO4, LR6, this is the shortcut we use in anatomy. That means the 2 muscles, superior oblique and lateral rectus, they both have a different nerve that controls it. Okay, SO4, superior oblique, is controlled by trochlear, lateral rectus by abducens. Other than these 2, everything else is cranial nerve number 3. Is everybody clear, folks? So SO4, LR6, everything else we could say 3. Okay, so that's the idea. Now, what else we know about cranial nerve number 3? Cranial nerve number 3 also have parasympathetic fibers in it. Okay, that's very important, folks. Now, we kind of talked about it on the first day when we were doing pharmacology. Cranial nerves are the nerves that carries all the parasympathetic fibers to the human body. Is that crystal clear, folks? Now, when we talk about that, 3, 7, 9, 10, these are the 4 cranial nerves that carry parasympathetic fibers, folks, okay? These are the 4 cranial nerves that carry the parasympathetic fibers. So now we are talking about cranial nerve number 3, which has both motor and parasympathetic. Now look at the cross-section, right? Now it looks like a simple cross-section, but this gives such a big understanding of some lesions. When I take a cross-section of cranial nerve number 3, in the middle, you have motor fibers. You could see that. Around, you have parasympathetic fibers. So if you cut the cranial nerve number 3, the peripheral fibers are parasympathetic, and the middle fibers are motor fibers. Is everybody clear, folks? Okay. Now, before we talk about it, let's talk about the function. Motor fibers innervates all the muscles of the eye, except those 2 muscles we talked about it. Now, when it comes to parasympathetic fibers, what do they do to the eye, parasympathetic fibers? They causes miosis, constriction of the pupil. Is that clear, folks? Constriction of the pupil is the normal function, okay? Constriction of the pupil is a normal function. Okay, that's a normal function. Now, we talked about the other day, when I put a light in the eye, the pupil should constrict, isn't it, folks? So that's done by, we said cranial nerve number 3, but now you know, to be more specific, it's the parasympathetic fibers of cranial nerve number 3. Is that clear, folks? All right. Now, when you come to a lesion for cranial nerve number 3, there are 2 types of lesions. We could talk about it. There is something compressing from outside. Imagine if there's something that compresses the cranial nerve number 3 from outside, which fiber do you think will be affected first? Parasympathetic fibers, isn't it, folks? So parasympathetic fibers is the first to be affected when there's a compression to cranial nerve number 3. Now, when that parasympathetic fiber is getting affected, the symptom of the eye will be dilation of the pupil. Okay, dilation of the pupil. Why? Because the parasympathetic fiber is getting constricted and now it's not allowing its normal function, folks. Okay, so this is very important when it comes to the eye, right? When we talk about brain dead, we check the eye and stuff. So it's important. So that's the first symptom. Now, if you look at this lady, for example, here, look at the normal people versus this big. Right? That tells you this eye. So we could say that's the patient's right eye. Okay, just to be talking. That's the patient's right eye. Right eye parasympathetic fiber is completely constricted because that's why they have a big pupil. Is everybody clear, folks? Now you could tell by looking at the pupil, the eye is dilated. So that means the cranial nerve number 3 is getting a compression from outside. Is everybody clear, folks? Now, so that's effect of parasympathetic fibers. As the compression gets more and more, you're going to start compressing or affecting the motor fibers. Is everybody clear, folks? So the minute motor fibers have a problem, the motor fibers cannot function. So these two will take over. Because the way eyeball is, folks, all the muscles are partially contracted. So when one don't work, the other one will take over. Does that make sense, folks? Now imagine we have the eyeball. In this side, this hand is medial rectus. This hand is lateral rectus. The minute my medial rectus don't work, my lateral rectus will pull over more. Does that make sense, folks? Now, so the lateral rectus will pull over this way. What is the function of SO4? Superior oblique is out and down. That's why we call SO4 is your copying muscle, folks. If you're sitting on a table and if you want to see what your friend is writing on that book, you need to use SO4, right? Out and down. That's what it's called, copying muscle. So that's the idea. Now, if you look at this patient's eye properly now, you could tell whether it's a parasympathetic fiber or motor or both are compressed. Is that clear, folks? Now, looking at this picture particularly, I could certainly say this patient has a parasympathetic fiber that gives you the dilation. Also, the eye is moving this way, so that's also affecting motor fibers. Both are involved in this patient. Is that clear, folks? But, how should it be if it is only parasympathetic fiber? The pupil should be dilated, but the eye should be still in the middle. Is that clear, folks? Now, that's why when patient comes, folks, like, for example, a brain dead, we're going to talk about it. One of the reflex we check is the eye reflex, right? Now, we could look at it and tell if it is worse or not, right? So for this patient particularly, I'm going to tell it's a pretty severe compression because parasympathetic and motor, both fibers are getting affected here. Is that clear, folks? If I were to see the eyeball in the middle, for example, I would say it's a mild compression. That's why it's only affecting the parasympathetic fibers, not the motor fibers. Is everybody clear, folks? So that's the best way to think, okay? So that's this. Is everybody clear to understand this? Okay. Now, after we understand that, cranial nerve number 3, it's very important because this is the upper cranial nerve, the top on the brainstem, right? So we said brainstem, for example, like this, isn't it? Your midbrain, pons, medulla oblongata. Where is the cranial nerve number 3 and 4 comes? 3 and 4 comes in the midbrain, isn't it, folks? So I could say that is the first cranial nerve all the way in the top, 3 and 4. 4 is going posteriorly, so we really don't care about 4. Cranial nerve 3 is the top cranial nerve or the upper cranial nerve, what we call it, folks. Why do we need to know that? Whenever there is a disease, what we call herniation. Herniation means brain is herniating down through a foramina. Okay, now let's talk about that a little bit. What's the name of the foramina that connects the brain to the spinal cord? Type it up. Name of the foramina that connects the brain to the spinal cord. Foramen. Start with M. Foramen magnum. Okay. Foramen magnum. That's the key. So now what happens, folks, when something, I want you guys to imagine the foramen magnum is somewhere here, okay, just for understanding. Anytime when there's a herniation, the structures are coming down, and the first cranial nerve that they affect is cranial nerve number 3. So everybody clear, folks? So whenever there's a brain herniation, the first cranial nerve to be affected is 3. Why? Because that's a top cranial nerve. That's the first one on the top. So easily they can compress. Is everybody clear, folks? So when people have a brain herniation, one of the main symptoms we're going to see, dilated pupil and possibly moving to out lateral. Is everybody clear, folks? So that's one of the key, folks. They're talking about uncal herniations. I'm going to talk about the herniation topics in a moment. So that's cranial nerve number 3. Is everybody clear, folks? Now, I could also tell, what if you see the eye that's moving to this side? Imagine exactly the same picture, but I'm going to tell the pupil looks completely normal. That tells you parasympathetic fiber is not affected, something wrong with the motor fibers only. Is that clear, folks? All right. Okay. That's the cranial nerve number 3. Any question for me about cranial nerve number 3? No. All right, let's move. Let's go to cranial nerve number 4. Okay. Now, what does cranial number 4 do? Superior oblique, right? So that's the idea here, folks. Pupil is higher than the affected eye. Characteristic head tilt to contralateral unaffected side to compensate for lack of intorsion. So you could literally say, when superior oblique is not working, your inferior oblique is going to take over. Does that make sense, folks? Inferior oblique is up and in. Okay, so that's the idea you could see here. That's the key, folks. Okay, so that's cranial number 6. But for me, what's important is cranial nerve number 6. More than 4, 6 is key, because 3 and 6, they have some confusion if you are not careful, folks. Okay. It says, what's the function of cranial nerve number 6? Innervates lateral rectus. If I want to look this pen, my right eye has to go lateral to look at it. Is that clear, folks? That's lateral rectus. Affected eye unable to abduct and is displaced medially in primary position of the gaze, folks. Okay. Now that's the idea. So if you need to look something laterally, you need to use this muscle to turn this way. Okay, that's cranial nerve number 6. Any question in this page?
Could you explain the difference between, because for the superior oblique and the inferior oblique, it's confusing what inferior oblique does, because I thought it was
inferior oblique up and in, superior oblique out and down and out.
Okay. For the inferior oblique, why is it in? Because when I looked at the notes on it yesterday, they were saying that it causes down and out, but in the rotation inward. So that's why.
So the way it works is, the way the muscle is innervated, it's located on the bottom, but when they pull the eyeball, the eyeball goes up and in. It's a way of the muscle attached to the eyeball. Okay, so we can't ask why, because anatomy, that's what it is, right? So the muscle, if it does that function, that's what it does. So superior obliques down and out, inferior oblique up and in. Okay, so that's its function. Any other questions? All right, so that's cranial of this part. Now there is something else we need to talk about. Before we come to this, okay, we're going to talk about this one. Intranuclear ophthalmoplegia, INO. Where did we come across this word? We came across this in multiple sclerosis, right? Intranuclear ophthalmoplegia. Now, this is super important to understand. Now, this is the idea, folks, okay? Now, take a look at me as an example. I have this, my pen on my left side. Now, if I want to look at this pen, my left eye should abduct this way. My right eye should be adduct. Is that clear, folks? So my right eye is using medial rectus muscles. My left eye is using lateral rectus muscles. Agree? So 2 different muscles, right? Now, if you see here, folks, let's take a look. So this is right eye, left eye, okay? Now, this is what the object is. In order to see the object, your right eye will use lateral rectus muscles because they have to go this way. The left eye will look at this way, so they use medial rectus muscle. Is everybody clear, folks? Now, lateral rectus is cranial nerve number 6. Medial rectus is cranial nerve number 3. There should be a coordination between cranial nerve number 3 and 6 whenever you want to look laterally. Is that clear, folks? That coordination is done by MIF, okay? MIF, that means it's MLF is actually, it's medial longitudinal fasciculus, okay? That is your medial longitudinal fasciculus. So medial longitudinal fasciculus is a structure in the brainstem that simply connect cranial nerve 6 and 3 to coordinate. Is everybody clear, folks? So that's what its function. If anybody asks you what does MLF does, it's coordinating between cranial nerve number 3 and 6. Are we clear, folks? That's the idea, okay? Now, that's a normal function. Does everybody understand the normal function? Now, sometime there could be a lesion. There could be a lesion to this MLF guy, okay? When there is a lesion to MLF guy, that's where we get that INO, which is your intranuclear ophthalmoplegia, okay? So intranuclear ophthalmoplegia mean, what would that be? Look at this, folks. Now, look at this one. Here, it is a normal picture that's showing. This one is using one muscle, this one is using the other one. Is everybody clear, folks? Now look at this, what's happening here. This eye is using cranial nerve number 6 and stimulating the lateral rectus. What muscle this should be using? Medial rectus by using cranial nerve number 3, isn't it, folks? But it's not doing it. You see that? So the eye is not coordinating. So everybody's following me, folks. So the eye is not coordinating, right? So one of the biggest misunderstanding people get when we talk about intranuclear ophthalmoplegia, which of the following cranial nerve is affected? Cranial nerve number 6, cranial nerve number 3, 6 and 3. What's the answer? Type ABC. Okay, so common sense to think both, right? The actual answer is B. Okay, actual answer is B. Why? When somebody is turning, look at this carefully, folks. I'm looking at an object here. My lateral rectus is already working. They are abducting. Does that make sense, folks? Who's not adapting here? Cranial nerve number 3 is the one doesn't want to stimulate this way. Does that make sense, folks? Now look at the notes. When cranial nerve number 6 nucleus activate ipsilateral rectus, lateral rectus, contralateral cranial nerve number 3 nucleus does not stimulate. So the problem is opposite side cranial nerve number 3. Is everybody clear, folks? Now this is something most of the students miss. When it comes to INO, it's a lesion of opposite side cranial nerve number 3, not same side, opposite side. Is that clear, folks? I should put option ipsilateral cranial nerve, contralateral cranial nerve number 3. It's always opposite because the same side is using 6. There is no need for 3. Does that make sense, folks?
Dr. Roy, so basically you gotta look to the medial side. That's the main issue here, right?
Say it again.
The main issue here is you cannot look to the medial side. That's it.
You cannot look at the medial side of the opposite side. See, if I have an object here, this side, my right side will move lateral, but this side cannot move medial. That's a problem. Okay, so that's why the eye stays in the middle, folks. Okay, so that's INO. Is everybody clear? So that's intranuclear ophthalmoplegia, folks. Okay, any question for me on this? Okay, so that's that. Let's see what else we need to know before we start dilation. We did this. Okay, let's go for this. We're going to talk about the visual field defect. This picture will not make any sense. I'm going to do a big drawing and you're going to have to copy that. This is the right eye, left eyeball. Now, let me explain before you continue drawing so it makes sense to you guys. Hang on a second. So we take a right eye If you take a right eye, we call this medial fiber. We call this lateral fibers because one is located medially, one is located laterally. Even though they are located medially, they actually takes the vision from this side. So we call that temporal vision, outside vision. And this fiber is located laterally. It takes nasal vision, medial vision, folks, okay? So they take the opposite side. It's like this one, this one, this. So everybody clear, folks? Now, if you see medial fibers doesn't cross, they stay on the same side. Sorry, lateral fiber stays on the same side. Medial fiber is the one that crossing to the opposite side. Do you guys see that? So medial fiber is the one that take the temporal vision, but they cross to the opposite side. Is everybody clear, folks? And this is your optic chiasma, this area, folks, okay? This area is your optic chiasma. Okay. All right, now go ahead and draw this and label it nicely. All good, folks? All right. So always remember, the medial fiber, take the peripheral vision. The lateral fiber, take the nasal vision. Okay. So that's how these things works, folks. Okay. Now, once we understand, we need to kind of talk about lesions. Okay. Now they have like approximately about 7 lesions, but the most important is your second lesion. Okay. This is what I am anticipating that's going to come in your exam because it has a good clinical correlations. So let's take a look here. So let's say a patient with craniopharyngioma, okay? Patient with craniopharyngioma, the pituitary enlarges because this is optic chiasma. On top of optic chiasma, we have pituitary, right? So the pituitary enlargement will compress this area, folks. So I'm just going to say here it's compressing, okay? The pituitary enlargement is compressing the optic chiasma. When I compress the optic chiasma, you see that only the medial fibers are affected. Is everybody clear, folks? Only the medial fibers are affected. Okay. Now, if I were to do an eye lesion for this, let's say I'm doing like this. This is your right side. This is your left side. This is the temporal vision, nasal vision. nasal vision and temporal vision, both eyeball, we are separating into half. So the lesion is to the medial fibers that takes the temporal vision. So the patient will lose both side temporal vision. Is everybody clear, folks? So what do we call this? Bitemporal hemianopia. Is that clear, folks? Because by both side temporal vision is gone. Okay. If you see the book, look at this one. Number 2. That's a perfect example. So that is what happened with the pituitary lesions and when it happens in the optic chiasma. Are we clear, folks? Okay. Now, the first one I skipped, you can simply say the entire nerve is disconnected for the right side. That's why the whole eyeball is gone. Is everybody clear, folks? All right. So this is my most important, folks, because of the exam, they have to give a scenario. It's always prolactinoma or craniopharyngioma, folks. Okay. Both can give you this. So that's that. Now let's take a look at another example. So let's say the same thing. Let's redraw the eyeball. Take a look. Yeah. Go ahead.
Sorry, that one was from the medial fibers, right?
Yeah. You see that when you see this is your medial fiber, only medial fiber is getting affected. Okay. Now, take a look here, folks. Now I'm cutting here. Now I'm cutting here. What will happen if I cut here? Left eye is the lateral fiber, that's the medial vision like this. Is everybody clear, folks? And the right eye, I cut the medial, so it's a temporal vision. You see, it's completely different. You see that, folks? That is your number 3. Look at this. Number 3. One eye is medial vision, there is temporal vision. What do we call that? Left homonymous hemianopia. If I cut on the right side, you just place it in the right side. Homonymous hemianopia. Okay. Now, I can tell you an example, what disease causes that we don't know that. Okay. That's why for step 1, they like us to number 2, because they take a pituitary lesion example. So, okay. That's the idea. So that's now. That much is up to here. So let's take a look. What I draw in the book up to here, folks, in my notepad. This is what we call optic tract. So this is your optic tract. Are you guys understanding it here so far? Now, what happened after the optic tract? The tract is dividing into radiation. Okay. It is going into radiation. 2 fibers, you can see. One is this, one is this. Now you will see that the tract is dividing into 2. One is going to temporal lobe, other one is going to parietal lobe. So it's dividing into 2. So in my drawing, I could simply say this one is dividing into 2. One is going to temporal lobe, one is going to parietal lobe. Is that clear, folks? So the radiation is going to temporal lobe and parietal lobe. Okay. So that's the idea. Now from here onwards, you can memorize it. You cannot ask why, because that's how it is made in the brain. Okay. So that's temporal and parietal. Now, look at here. If you take a lesion number 4, that means there's a lesion to temporal lobe, radiation. We are using the same as number 3, but only upper half. You see that. It's almost like number 3, but not the entire, only upper half. You see that, folks? Because it's a lesion of optic tract continuing into the radiation. Is that clear, folks? Now, look at the next one. It is also same, but lower half. You see that, folks? I'm going to write this as a temporal lobe. This is the parietal lobe. Temporal lobe and parietal lobe. Now, the easiest way to memorize this, the way I think in my brain, temporal lobe is right here, parietal lobe is here. So parietal lobe is up, temporal lobe is down. Does that make sense, folks? So the way I remember, the lesion is opposite. If I have a lesion on the temporal lobe, even though it's located at the bottom, the effect is in the upper part of the eye. You see that? When you have a parietal lesion, it's located on the top, but the effect at the lower part of the eye is opposite to where it's located. I mean, that's what I use to remember. I don't have a problem with it. But whatever it helps you have to remember, that's okay. So that's the lesion and temporal this, folks. Okay, they have to give an answer. Okay, if you see guys have an AMAs, they will never ask you. They can ask this. Number one, number highlight because they say simply one line is simply that's too easy. They could ask you this, or they could ask you this. Okay. The last one. The last one is a manual generation. Everybody's looking at numbers all the way back. No, mathematical is there. That's clear, folks. So the number 7 is here. Okay. Number 7 is here inside. So those are the best way to remember it. So that's your visual field effects. Okay. So what? The best understanding you need to know those real and lat fibers so you understand them, folks. Any question?
Yeah, right. You like the number 4 and then number 5. So it will be on the side of the main blue part or
It's only one side.
No, I mean the lesion. They can have the cross on the side and the other side fibers, yeah?
What do you mean? So no, you don't need number 4 on one side. Either this is the left side, either left side or right side. You cannot have both.
Okay.
Because if you were to have both, it should affect all upper half of the eye. It's not only on one side. That's why if you see the lesion here, it's only half of the eye. So it has to be on one side of the brain. Either it's right side or left side. Okay. The lesion has to be that. Any other questions? Okay. So that's that. Now last one. Cavernous sinus. So the anatomy of cavernous sinus, folks. Okay. Now we're going to talk about this in the blood vessels. Okay. Now I want you guys to tell you guys did the arterial system, right? Tell me when the blood goes from internal carotid, right? So from aorta, the blood goes to internal common carotid. If I have to write it properly. From common carotid to internal carotid, right? Internal carotid, where does it go? All the cerebral arteries, right? All the cerebral. But to be more specific, it should be an anterior circulation. Anterior circulation, right? Anterior circulation, cerebral arteries. Cerebral arteries. I could do a little picture here. Anterior circulation also comes to cerebral arteries. On the other hand, posterior circulation also comes to cerebral arteries. Does that make sense, folks? Okay. Who's the posterior circulation? Basilar artery. How do you get basilar artery? Joining of two vertebral arteries, isn't it? So I'll just put V, vertebral artery. Where does vertebral artery come from? Subclavian artery. Where does subclavian come from? Aorta, right? Technically. Right. Is that clear, folks? This is how the blood comes. Finally, it becomes cerebral arteries, anterior, posterior, whatever. It's in there. Do you understand this, folks? Okay. Now, once it becomes cerebral artery, they go to become, say, the capillaries, and then they become bridging vein. Bridging veins. That's where all the venous blood. There's no specific vein. We call it bridging vein. When there's a rupture to bridging veins, what type of hematoma is that? When you have a bridging vein, what? Subdural hematoma, isn't it? It's subdural hematoma. Okay, good job. So bridging vein is where all the venous blood is collecting. That bridging vein will drain all the blood to cavernous sinus. A cavernous sinus is like a pool where all the blood is accumulating before they leave the brain. Is everybody clear, folks? From cavernous sinus, you have internal jugular vein that originates, folks. Okay, from a cavernous sinus, you have internal jugular vein. Okay, I repeat, cerebral artery to bridging veins, bridging vein to cavernous sinus to internal jugular vein. Where does internal jugular vein goes? You guys know this from respiratory. Come on. Internal jugular vein joins with subclavian vein. Internal jugular vein joins with subclavian vein to form brachiocephalic vein. Brachiocephalic vein. And both side brachiocephalic vein joins and form SVC. Is that clear, folks? Why is only some heads are shaking? Anybody? Please ask me if you lost here, because otherwise I can't make sense out of it. Everybody clear, folks? Carrie, good? Okay. So in another word, what I'm telling, if I inject a dye or some contrast material in the aorta, I should see it on my SVC. Agree? It should, right? It should go and come back. Okay. This is the whole circulation of the brain, folks, how blood goes. Oxygenated blood enter, carbon dioxide come out. Is that clear, folks? So the cavernous sinus is like a pool where the blood are filling before they come out of the brain. Is that clear, folks? That's what cavernous sinus is. That's the anatomy. Okay. Collection of venous sinuses on either side of the pituitary. You could see that. Okay. Now, the only thing that you have to be a little careful. Did you guys copy this, folks? You guys should have that in your book. Okay. Let me know when you are done copying.
Dr. Roy, what did you write after aorta? Because my brain is not
Oh, common carotid artery.
I wasn't sure, but I just wanted to know. Thank you.
Common carotid separates into internal and external, right? So, yeah. Sorry. So they say good doctors has a bad handwriting. So let's repeat one more time. Aorta become common carotid, that then become internal carotid, anterior circulation. From subclavian artery, there is a branch vertebral, become basilar. Basilar supplies the posterior circulation. They both all at the end of the day go to all the different type of cerebral arteries. Once arterial blood becomes vein, we call it bridging veins. The bridging veins pull all the blood in the cavernous sinus and then they drain into internal jugular vein. Now, there's only one part I want to add. You see this area in my eye, right? This area. Okay, this area of the skin drains blood, venous blood. Is that clear, folks? This vein, area that drains blood from this area, they have a blood can connected to cavernous sinus. Okay, we call it periorbital area, this area, okay, eye area. So anytime you have a blood that comes from here, there's also a little connection to cavernous sinus. Why do we need to know that, folks? Sometime what happened, people get infection of this area, okay? Anytime they have a skin infection of this area, that infection can spread to cavernous sinus. Is that clear, folks? So people wonder, how can this infection go all the way deep to cavernous sinus? Because the venous drainage from this area has that communication to cavernous sinus. Is that clear, folks? You should know that. This is actually a step 2 CK question. You will get this question, but I'm mentioning in anatomy so you know it, okay? So that's why we tell people, let's say if we have an infection on the cheek, we don't care. But if you have an infection in this area, you don't mess around. You need to get treatment ASAP before it goes into cavernous sinus. Is that clear, folks? All right. So there's a connection to cavernous sinus. Now, if we go here, we're going to talk about cavernous sinus syndrome. Okay, so cavernous sinus syndrome is basically cavernous sinus is infected. That's all it is, folks. Okay, cavernous sinus is infected. Presence with variable ophthalmoplegia, decreased corneal sensation, Horner syndrome, and different sensation, folks. Okay, they could get cavernous sinus thrombosis. Okay, look at this: infection spread due to lack of valves in dural venous sinus. One of the things you should know, above the neck for veins don't have valves because it's gravity, isn't it, folks? So that's one of the key, folks. Okay, now they didn't talk about the specific infection around the eye. They do talk about that on your step 2 CK, so don't forget that, folks. For step 1, what do they ask? They talk about cavernous sinus syndrome. They ask you which of the following cranial nerve is not affected. And look at this one. All these are cavernous sinus. Do you see V1 and V2 is there, but V3 is not there, folks? Have you noticed it? V3 is always intact, mandibular branch. Okay, V3 should be always intact from cavernous sinus infection. So you should know mandibular branch should not get affected in cavernous sinus. Type up the name of the disease we studied on Friday. That disease also don't involve V3. In neuro, you should know 2 diseases don't involve V3. One is cavernous sinus syndrome. The other one is whatever it is, type it up. What's the name of the disease? They have something on the face too, right? Port wine stain, remember that? What is the disease? It's the first one on the page, but I cannot remember. Serge Weber. Okay, so that's the one. All right, so that's the one. If you remember, V1, V2, V3 is not affected, folks. Okay. Okay. Very good, folks. So that's cavernous sinus. Is everybody clear? Okay. So this take care of the cavernous sinus part. Okay. Let me go through here. This. Okay. So now let's get into the brainstem lesion, folks. You see, all the things are done. Now, when it comes to brainstem lesion, I will give you enough time. We have the rest of the whole day. It's just for brainstem lesion, folks, because we're going to do brainstem and pharmacology. That's all we're going to do today. Don't write it down now until I explain. This is one of the most difficult to explain and also understand. Okay, because we're going to study 6 lesions. It's very hard. So I don't want you guys to write anything now until I finish it. Okay, so what I'm doing here, this is your midbrain. This is your pons. It's a schematic diagram. That's your medulla oblongata. Okay, so I'm doing a schematic diagram with 3 structures. Okay, don't write this. Watch it carefully. Now, I divide it into both left side and right side. Or right and left, it doesn't matter, folks. Okay, so we have right side of the midbrain and the left side of the midbrain. Same applies to pons and medulla oblongata. Is that clear, folks? Now, we divide further like this. What does that mean, folks? This is where the confusion starts again. Pons has left side medial and left side lateral. Is that clear, folks? See, I'm only talking about the left side. Left side itself has their own medial and lateral. Same thing to the right side. Right side has medial, right side also has lateral. Is everybody clear, folks? Same thing applies. Medulla oblongata, Left side has medial medulla, lateral medulla. And then again on the right side, they have their own medial medulla and lateral medulla. Is everybody clear, folks? Now, how come I didn't involve midbrain into it? Because when it comes to midbrain, we divide a little bit different, okay? We divide a little differently. When it comes to midbrain, we divide it into medial midbrain, dorsal midbrain posterior. There is no lateral, okay? There is no lateral. So it's medial or dorsal. This is how anatomically we differentiate. Is everybody clear, folks? This is important, okay? Now go ahead and copy this properly. All good, folks? Anybody else need more time? All good, okay. Now, keep the pen away and watch. Now, why do we need to know that medial and lateral, right? So what happens is there are structure. When I say structure, these are tracks because that tracks is going up and down from spinal cord to brain, isn't it, folks? Now, there are some tracks, for example, I would say that traveling medially like that. And there are some tracks that travels laterally like that, right? We don't know that. So there are some tracks goes medially, some tracks goes laterally. Now, then you could have a lesions. You could have a lesion to the track here or the lesion to the track here. So take a look at this. I'm going to name this track X right now. I'm not going to name it. I could have a lesion for track X at the level of pons or at the level of medulla oblongata. Is everybody clear, folks? Symptom will be the same. Why? It's the same track. Whether I have a lesion at the level, this is like a first floor, this is like a second floor, but it's the same structure. Does that make sense, folks? Let's say this track is track Y. I could have a lesion here, or I could have a lesion here. It's the same symptom, but the different level. Is everybody clear, folks? So most of the time, or most of the schools, how they teach, when they have a lesion in here, for example, let's say we have a lesion here, we call medial pontine syndrome. Why do I call that? It's happening in the medial part of the pons. Is that clear, folks? If it happens here, we call it medial pontine syndrome. If it happens here, it's called lateral pontine syndrome. Is everybody clear, folks? And the same thing applies to medulla. When it happens here, that's medial medullary syndrome. And here, lateral medullary syndrome. Is everybody clear, folks? Now, most of the people learn or teach how to differentiate lesion from medial to lateral. I think that's a wrong way of studying because it's so easy to tell the difference between medial and lateral because it's two different structures, isn't it, folks? You know that track X is for medial and Y is for lateral, so completely opposite track. That's easy to tell. The difficult part, how do you tell the difference between medial pontine versus medial medulla? Because it's the same structure. Does that make sense, folks? It is same structure. We need to learn how to differentiate medial pontine syndrome from medial medullary syndrome because it's exactly same structure going up and down. Is everybody clear, folks? All right. So that's what we're going to learn. So now let me erase these things a little bit. Okay. What we're going to do on the next page, we're going to list medial medullary syndrome versus medial pontine syndrome. It will start making sense once we do it, folks, okay? So I have medial medullary and medial pontine. So that means I am actually talking about these two boxes. So I'm going to do a lining here, folks, okay? Let's say I'm talking about the lesion of this. Is everybody clear, folks? That's the lesion I'm talking here. Now, what we're going to do here, it's medial medullary syndrome, medial pontine, two different levels. I'm going to write all the structure that runs commonly for both medial medulla and medial pontine, folks. What are the structures that runs commonly? First, corticospinal tract. Corticospinal tract. Dorsal column, medial lemniscus pathway. Okay, dorsal column, medial lemniscus pathway, folks. Okay, dorsal column, medial lemniscus pathway. These two structures are running medially. So I'm actually going to do the two structure like that. So I'm going to say corticospinal, dorsal column, medial lemniscus. You see that, folks? Both of these tracks are traveling medially, okay? Both of these tracks are traveling medially. Now I could have a lesion for both of the track at the level of medulla or at the level of pons. It will be exactly the same symptoms. Does that make sense, folks? So what will be the symptom? I want you guys to help me. If I have a lesion in corticospinal tract, what will be the presentation? Let's assume I have a lesion on my right side brain. That means the tract, everything crosses, isn't it, folks? So if I have a lesion on my right side of the brain, I'm going to lose all the function on the left side of the body. It's always contralateral. Is that clear, folks? So I'm going to write contralateral hemiparalysis. Hemiparalysis means half of the body below the neck, I cannot move. It's a motor problem because corticospinal tract is a motor problem, isn't it, folks? Yeah, motor problem. What about dorsal column medial lemniscus pathway? What is the function of that tract? Tell me the function.
Proprioception and vibration.
Proprioception, vibration, position sense, everything, right? All right. Now, when you have a lesion from dorsal column medial lemniscus, what will be the problem? Again, contralateral, because that's also crosses. Contralateral loss of proprioception, vibration, position sense, all these things. Okay, write that down. Now, anytime a patient comes to you, the patient has two complaints. Below the neck, left side, for example, they cannot move any muscles or they cannot feel any position, vibration, sense anything. You know it's either medial medullary syndrome or medial pontine syndrome. Is everybody clear, folks? Anybody lost so far? No. Okay. So whenever you have these two tracks involved, there is no way you could tell which level is the lesion. You cannot tell. Only option you could give, it's either medial medulla or medial pons. Agree, folks? Now we need to come up with a unique finding for medial medulla and medial pons to tell which level you have the problem. Is that crystal clear, folks? Now, the unique finding for medial medullary, here you have cranial nerve number 12. Write that down. Cranial nerve number 12. And for medial pons, cranial nerve number 6. Cranial nerve number 6. So 12 and 6. So I could write it on my page. 12 and 6. That's a unique finding for this area. Okay, that's the idea. So what does that tells you? What's the function of cranial nerve number 12? Hypoglossal. It's a motor function of the tongue, isn't it, folks? And keep in mind, when it comes to cranial nerve, it's always ipsilateral. There is no contralateral. Okay, so ipsilateral. So that means the tongue is going to deviate to the same side of the lesion. So now I'm going to tell this. You should always know, watch me carefully. Whenever you have a problem like this, in your face, it will be one side, the body should be opposite side. Is that clear, folks? So in this particular lesion, if I tell you I have a right side brain problem, tongue will deviate to the right and my body will be left side. It cannot be the same side of the face and body at all, folks, okay? It should be opposite side. So cranial nerve number 12, it's a tongue deviate to the same side, okay? So you guys know that. So if any time you read a question, corticospinal tract and DCML with cranial nerve number 12, you know it's a medial medullary syndrome. Is everybody clear, folks? So the only unique feature is cranial nerve number 12. Yeah, Alize, what's up?
You meant it's on the same side where both of the other lesions are, right?
No. Yeah, in the brain is the same side, but the presentation for the cranial nerve, it will be on the same side, but below the neck, it will be on the opposite side because the tract crosses to the opposite side. Yeah.
So, okay, the lesion would be on the opposite side, right? That's what you said. The cranial nerve.
No, it's the same side of the brain. So let's assume I have a right side brain injury. my tongue will deviate to the right side because it's on the same side, and my body will be left side.
Okay.
Now, is everybody clear with that, folks? Now, what about cranial nerve number 6? What's the function of cranial nerve number 6? What did we just study? Cranial nerve number 6 is abducens, isn't it? If that doesn't work, what happened? The medial will take over, isn't it? So the eye will look medially. What is the fancy word for? Medial strabismus. So anytime your eye look medially, we call medial strabismus, okay? Now, if a patient comes with these two tracts and medial strabismus, we call that medial pontine lesions. Is that clear, folks? So what is the differentiating feature? Cranial nerve. So you could ask me, so when we do a question, can I just focus on the cranial nerve? No, because you could also get isolated cranial nerve lesions. You have to combine both. Okay, you have to combine both. Is everybody clear, folks? So that's medial medullary and medial pontine. Did everybody understand this lesion, folks? These two? Okay, that's why so now you could go put, you see, 12, and so you know the name of the tract and you know the muscle, the cranial nerve, so you cannot go wrong. So this is the easiest 2 diseases out of 6. Okay, these are 2 lesions. Now you need to know what causes this lesion. What causes this lesion? We're going to write it down. Medial medullary syndrome is caused by blockage of anterior spinal artery, ASA. Anterior spinal artery. Anterior spinal artery. And the medial pontine syndrome is called by blockage to the branches of basilar artery. Basilar artery. I would also put that here, folks. Medial, this one is ASA. Don't think ASA mean aspirin. It's anterior spinal artery, okay? Because aspirin also wrote as ASA short form. And this one will be basilar artery. See, at the end of the day, folks, you should only have this diagram. And when you look at the diagram, you should be able to recall all the 6 diseases in like 5 minutes, okay? So you make the diagram big as possible, okay? So you could, you could do it again in the afternoon when we are done today. So that's that. The more you write, the best it is, folks, okay? It's not easy, folks. I've been teaching this for 9 years. I still carry my notes in my hand just for brain stimulation because I want to make sure I don't make a mistake. It's not easy, okay? So that's 2 lesions we just studied. Is everybody clear, folks? Now, if you want to see exactly where this happens in your circle of Willis, let's go to this picture. You see here, folks, in this diagram, I could literally, I'm going to draw it here, folks, 1 sec. You see, this is medial pontine, this is medial medullary. Do you guys follow this, folks? That's exactly where that lesion is happening. Now, if I have to draw it in this diagram, that's medial pontine. That makes sense because that's a bacillary artery. This is the branches of the bacillary artery. You see that? Okay. And here is the medial medulla. Anterior spinal artery is the problem that supplies this area. Is that clear, folks? That's where that lesion is happening. Now, in the same diagram, if I go laterally, I have lateral pontine and lateral medulla. Is that clear, folks? That's what we're going to learn now. So that concludes your medial medullary and medial pontine. Any question for me? Like crystal clear? Two tracks.
Dr. Roy,
Uh,
sorry, for the medial Pontin syndrome, what exactly like the clinical for the eye movement?
So
Like,
eye
I'm kind of-
movement, your cranial nerve number 6 is affected, right? What does
Mhm.
6 do?
So it controls the eye movement, right?
Which side 6 controls? Which side? If I ask you, what does the function of lateral rectus? What does it? What do you say? It's looking out, right? Outside.
Yeah.
So when there is a
So
lesion,
the
the eye is going to look medially. We call that medial strabismus.
okay.
Okay.
That would be also on one side, or that
One
would be
side.
also on
Only one side, because if you have a problem of cranial nerve 6, it has to be unilateral. Because remember, we're only talking about right side lesion, not both.
Mhm.
Okay. So it's only the affected eye. Only one side. Because look at this diagram. In the pons and medulla, we are only talking about one side. I didn't include the other side. You can't get that lesion. People will be dead if they have that messy type of lesion in the brainstem. Okay. Is everybody clear? So easy to remember. Medial medulla, medial pontine, 2 tracks and cranial nerve. Is that clear, folks? 2 tracks and a cranial nerve. That's all it is. Okay. Corticospinal and DCML with cranial nerve number 12, we call medial medullary syndrome. The same track with cranial nerve 6, we call medial pontine syndrome. Are we clear, folks?
Sorry, just to verify, so would only be one eye affected, is what you're saying?
Yeah. Because remember, if you have injury to the right side of my brain, it's only affecting the right cranial nerve. It's not affecting my left cranial nerve.
So it'll be ipsilateral. I mean, it'll be on the side where the brain
Always
injury.
remember, cranial nerve lesion is always ipsilateral. There is no contralateral. I repeat, you can't use the word contralateral in the cranial nerve. It's always ipsilateral. So that means in the patient, if I have a right side lesion, all my face will be right side, my body will be left side. Okay. Now on the next page, we're going to start lateral medullary lesion. Pay attention, this is going to be difficult. Lateral medullary syndrome, lateral pontine syndrome. So what are we talking about now? We are talking about this. Agree, folks? We're going to talk about these two. Okay. Now I'm going to start writing the normal functions or the normal structure that involved in this, folks. Normal structure. Spinocerebellar tract. Spinocerebellar tract. Spinothalamic tract. Vestibular nuclei. Start writing, okay? Spinocerebellar tract, spinothalamic tract, vestibular nuclei, spinal V5 nuclei. I will explain what it is. Just write it down. And ipsilateral Horner syndrome. That's common, Horner syndrome. That's the last one, Horner syndrome. You see, all these structures are involved on both. So that's like 1, 2, 3, 4, 5. All these 5 structures are running here, folks. You see, all the 5 of them are running like this. Is that clear, folks? You should draw. I don't have a space because my drawing is small. You should put and label it each of them in here. Is everybody clear, folks? I could still do it, but it's 5 structure. They're running lateral pontine and lateral medulla. Okay, those are the 5 structure. Okay, now let's start with the symptom. What will be the symptom if you have a lesion to spinocerebellar tract? Somebody tell me. You could verbally say it. What is it? Abby, try.
It's when you cannot like walk right, ataxia when your eyes are open.
So what do we call that? Balance and equilibrium,
ataxia.
right? So when you have a balance and equilibrium, what did you say the word A? Ataxia. So the patient will have ataxia. Ipsilateral or contralateral?
Contralateral.
Contralateral. What do you think, Alize? Ipsilateral or contralateral?
Ipsilateral.
Why it's ipsilateral?
Because of the I forgot it was up and down on the same area.
No, that's not the answer. It is still ipsilateral. The reason behind this, that is the only tract that does not cross. This is the only tract that we draw in the pictures that never crosses. It always stays the same, okay? So ipsilateral ataxia. So ipsilateral ataxia. So they will fall towards the same side of the lesion. What about spinothalamic? Pain and temperature lost below the neck. Is that clear, folks? Contralateral. Contralateral. Remember, below the neck, everything is opposite side. Contralateral loss of PNT. Pain and temperature. Pain and temperatura. Pain and temperature. Now, you wonder, we talked about it. We have spinothalamic tract to carry the pain and temperature of the body below the neck. How about the face? Who carries the pain and temperature? It's a trigeminal nerve, isn't it, folks? That's what the stand for spinal V. V mean 5. That's a trigeminal nucleus, right? So you should know it's ipsilateral pain and temperature of the face. So how do you think this patient will come? Let's say if I have a right side lesion in my brain, I will lose pain and temperature of the face of the right side, body on the left side. Is that clear, folks? All opposite, okay? All opposite. So that's spinal nucleus. And then you guys know what is Horner syndrome, meiosis, and all these symptoms. Okay, so that's easy. Vestibular nuclei. What's a symptom? What is the function of vestibular nuclei? When I say vestibuli, that brings you to a question. What's the name of the cranial nerve number 8? Look at
The
this.
same thing, isn't it?
People are doing mnemonics for cranial nerves. Unbelievable. What's the name of it? Cochlear? What is it? Vestibular? Cochlear, right? Vestibular cochlear. You know, in undergraduate of human anatomy, we studied this actually 13 cranial nerves. Only for medical students, it's 12. The reason, cranial nerve number 8 actually is 2 cranial nerve attached by a connective tissue. When you dissect, it's easy to separate. So if you separate the vestibular cochlear, there is one nerve for vestibulum, there is another nerve for cochlear. Cochlear is for hearing, and this is for balance. Everybody clear, folks? That's why sometimes people have a problem of balancing, but they have no problem in hearing. Some people have a hearing loss, but they have no problem in balancing because it's 2 separate nerves. Is that clear, folks? All right. Now, when we talk about vestibular nuclei, it is only balancing issue. It's a nuclei for balancing, right? So patient is going to feel dizzy. So would this be ipsilateral or contralateral? The symptom, which part of the body they will feel dizzy?
Ipsilateral.
Ipsilateral. So what Abby is saying, a human can feel dizzy on the half side, on the other side, they will be perfectly normal. Okay. No, so when it comes to dizzy, we don't say ipsi or contralateral, okay? I'm just pulling your nerve. So when people is dizzy, they are dizzy, right? You know, you can't tell, you know, I feel dizzy on my right side, but I feel perfectly okay on the left side, right? So that's dizziness. Okay, that's vestibular nuclei. You see, folks, all these symptoms tells you it could be either lateral medullary syndrome or lateral pontine. Is everybody clear, folks? Now, same story. How do you separate here? I'm going to tell cranial nerve number 9 and 10, specific for medullary. 9 and 10. So we're going to call it like that. Is that clear, folks? 9 and 10. So I'm going to go write this here. 9 and 10. 9 and 10. Okay, 9 and 10. That brings you. What's the function of 9 and 10? Somebody go. Come on, folks. 9 is glossopharyngeus and 10 is vagal nerve, right? So when I tell 9 and 10 is involved, the first major thing that you should think, loss of gag reflex. Because for you to throw up, we need both nerve. Does that make sense, folks? One for sensory and one for, okay. What else? Dysarthria, dysphagia, so many issues there, folks. Okay, you all cranial nerve 9 and 10, so you should know all the functions. And all of them will be lost, okay? Can you get hoarseness? There you go. Okay, so all the nerve of cranial nerve 9 and 10. So if you read this question, symptom, and then you see one of this cranial nerve involved, then you know it's a lateral medullary syndrome. Is everybody clear, folks? Now, what about lateral pontine syndrome? That's going to be very interesting. Cranial nerve number 7 and 8. What does that mean? What is 8? Vestibulocochlear. They already have vestibular involved. So what am I looking for? Hearing loss. So the hearing loss will be a big hint. What about cranial nerve number 7? Facial Bell's palsy. Is that clear, folks? All the cranial nerve number 7. Tell me the functions of cranial nerve number 7. Come on. Somebody else, not Abby this time. Carrie, list all of them.
So you have hyperacusis, you have problems with, depending on what part of the nerve, it'll be the top half of the face and the lower half of the face where you'll have kind of deviation.
So the
to other
facial
side.
palsy, that's fine. Go to the other functions. Two
Hyperacusis,
I'm expecting.
pain and temperature, or like pain and sensation.
Pain and temperature is trigeminal. We just mentioned it in the previous, so it can't be that. What do you think of it? Tear production.
Mhm.
Tear production, you need facial nerve. One more. What else?
Salivation.
Okay, no, still. Tongue, involve the tongue. Can you tell me something? Sensation of anterior 2/3 of the tongue.
Yeah.
Taste and sensory of the anterior 2/3. Who takes the posterior 1/3? Wayne, why you give me that face?
I thought the tongue sensation was trigeminal and
No.
taste was no.
Anterior 2/3 facial, posterior 1/3 glossopharyngeal. Okay, so all these functions are lost for lateral pontine syndrome, folks. Everybody clear? Now we could go add here 7 and 8. 7 and 8. So that is your lateral medullary syndrome and lateral pontine syndrome, folks. All good so far? Now we need to know the cause. What causes this lesion? That's the whole point. Lateral medullary syndrome is caused by PICA. P-I-C-A. What does that mean? Posterior inferior cerebellar artery. I'll show you on the picture in a moment. Posterior inferior cerebellar artery. And also remember, folks, lateral medullary syndrome has another fancy name we call Wallenberg syndrome. You heard that word before.
Doctor, so for the facial, it does the taste, but the trigeminal does the sensation of the 2/3.
That's a temperature. Taste is different, temperature is different.
Yeah, so somatic sensation is the touching of the tongue, right?
Or any pain, you could say pain and temperature is your sensory nerve, but when it comes to taste, it's facial nerve.
Yeah, got it.
So this is Wallenberg syndrome, and pica. Okay, don't forget in the exam, Wallenberg mean lateral medullary. Now, lateral pontine is ICA, same thing, but instead of posterior, it's anterior. Now, if you go here, look at that. Now, this is posterior inferior cerebellar artery, right? That's for, here should be your lateral medullary box. That's where that should be. Now, this should be the lateral pontine, and this branch actually goes a little bit up. Okay, so that's how you want to remember it. But one of the key part that you want to notice it here, just for lateral medullary syndrome. This is where lateral medullary syndrome is happening. So that's your pica. Did we get that? I was told by a student, they checked the Wallenberg syndrome on the step 1 exam. They asked what artery. They did not give this branch. So what do you look for? What else could be? So it's a blockage, right? Some embolism is blocking. That's what causing it. So if you don't find a word of pica in the exam, what else you should be picking?
The vertebral branch.
Very good. This is your vertebral artery. You could have a blockage in the vertebral artery. So it's either pica or vertebral artery, folks. Okay. Both of them are a right answer. They will never give you both, but if they don't give pica, they will give you symptoms for vertebral artery. What will be the symptom or some finding on a patient if the vertebral artery is damaged? Where you should have fracture. Don't curse, Carrie. If the answer don't come. What is that? Transverse foramina fracture. If you have a transverse foramina fracture, it will damage the vertebral artery. Is that clear, folks? All right. So you could write it down in here. It's pica or vertebral artery. Vertebral artery. Is everybody clear, folks? Okay. Now that concludes 4 syndrome of 6. Okay. Now let's recap one more time. Don't look at the book. Let's talk about medial medullary and medial pontine. Okay. So that's medially. So we say there's 2 tracts that common for medial medulla and medial pontine. These are corticospinal tract and dorsal column. Are we clear? Now, a unique cranial nerve for medial medullary is 12, and unique for medial pontine is 6. Are we clear, folks? See, if you know that, then you will come up with the symptom. That's the most important to remember, okay? So now once you know it's 6, then you know if you have a lesion, the eye is going to look medially, so we're going to call it medial strabismus. Okay, so that's medial medullary. Now, you could see that, okay? Now, when it comes to lateral medullary and lateral pontine, common structure, spinocerebellar tract, spinothalamic tract, spinal V nucleus, then you have what else? Vestibular nuclei, right? 5 things, one more, Horner syndrome. Now, in my opinion, to make it easy on the exam, I look for spinocerebellar and spinothalamic tract. As soon as I have these 2 tracts, I kind of concludes it's a lateral lesion because they are very specific, saves time, okay? And then we say the unique feature for lateral medullary is cranial nerve 9 and 10. For lateral pontine, 7 and 8. Is everybody clear, folks? Even for lateral pontine, I kind of look for hearing loss. If I see a hearing loss, then I know it's a lateral pontine. If I don't hear it, then I know it's not that. Is that clear, folks? So that's a 6 lesions we have done. You see that? Now, you should ask me, how come we never involved midbrain in the part of this? Because the way the midbrain is dividing medial and dorsal, that's why we cannot bring into compare with the other 2 lesions, folks, okay? So when it comes to midbrain, they're a little bit different and unique. So how do we work with that? Simple. Medial midbrain lesion, dorsal midbrain lesions, 2 separate effect, okay? So that's the easiest one. The last 2 lesions, medial midbrain syndrome, dorsal midbrain syndrome. Medial midbrain and dorsal midbrain. Okay. Medial midbrain. So there's no common features anymore. They have their own features, folks. Okay. So it's going to be very easy here. There's going to be corticospinal tract and cranial nerve number 3. That's it. Those are the two things. That's it. How hard is to remember this? Corticospinal mean opposite contralateral loss of motor function, hemiparalysis. What about cranial nerve number 3? If you have a cranial nerve number 3 lesion, where would the eye look? Outside. So that should be lateral strabismus. Cranial nerve number 3 lesion gives you lateral strabismus. Cranial nerve number 6 gives you medial strabismus. Don't confuse. The name comes where the eye is looking, okay? Where the eye is looking. So that's medial midbrain. It's a very easy one. It also has a different name for medial midbrain. What do we call that? Weber syndrome. Everybody knows Weber syndrome. That's Weber, okay? PCA is blocked. Posterior cerebral artery, not cerebellum, cerebral artery. Posterior cerebral artery. So I could go back and put in this drawing cranial nerve number 3. Is everybody clear, folks? And then add a track if you want, corticospinal. That's all it is. Actually, I could continue this, right? So that's that. Now we have dorsal midbrain. Now we're going to talk about this. Before we talk about this, we need to know the cause of it. The reason people get dorsal midbrain syndrome, it has another name for it. We call Perrinard syndrome. Did we come across this? What's Perrinard syndrome? What causes Perrinard syndrome in another word? Type it up. Everybody need to type it up. Where did we come across Perrinard syndrome? Perrinard syndrome is caused by a tumor. What tumor is that? I have one answer. It's pineal gland tumor. Pineal gland tumor. Okay, watch me first before we continue. This is something that you are looking at laterally. Let's say you are looking through the side view, okay? When you look at the side view, that's pineal gland. Next to pineal gland, there is a two structure. It's called superior colliculus and inferior colliculus, okay? Superior colliculus and inferior colliculus. This is a cerebellopontine angle. That's the anatomical name for that area. Now, the way to remember, superior colliculus is for vision, inferior colliculus is for hearing, okay? That's their function. How do you remember? Look at my ear. Which one is higher, my eye or ear? Eye is higher than the ear, isn't it, folks? So that's why superior is for the vision, inferior is for the hearing, okay? Now, when people have pineal gland tumor, imagine the tumor is developing big and they compress superior colliculus. They only compress superior colliculus. So when they compress the superior colliculus, what do we think is happening? Some symptom on the vision. Is that clear, folks? So we're going to use the word vertical nystagmus. I know people get worried with the word of nystagmus. What is nystagmus? It's like your eye is shaking, tremor, thinking that way. So there are two types of tremor. I can go horizontally or it can go vertically. This one gives you vertical nystagmus, folks, okay? So I'm going to write one of the symptoms, vertical nystagmus. Vertical nystagmus. The next symptom, they also compress cerebral aqueduct. They also compress cerebral aqueduct. What will be the diagnosis? If you compress the cerebral aqueduct, Mallory, what's the diagnosis? I can hear you. Are you trying to give a hint, hearing loss? No. It's going to be, okay, non-communicating hydrocephalus. Is that what you're saying? Sure. All right. It's a non-communicating hydrocephalus. Okay. Hydrocephalus. Because remember, when you compress cerebral aqueduct, you are blocking the communication. Okay. See, there's no tracks, nothing involved in this. Okay, folks. That's your dorsal midbrain. Don't ask me for the blood vessel, because why? What causes the Perinaut syndrome? Pineal gland tumor, folks. Okay. Pineal gland tumor is the one that causes it. So that concludes your 6th lesion of the brainstem, folks. Okay, 100% one question, you're going to get it. I'm going to show you one question of the difficult one, so then we could get all these.